So hi everyone. It's great to have an opportunity to sort of share with you all this study. We were sort of on the bill for last month, and it just there was so much to talk about with marijuana. Obviously, this needed to go to a separate meeting. I wanted. My name is Susan Graham. Just to introduce myself. I am a provider at Madison I'm the only provider at the Madison Satellite Clinic in Olympia. So I see patients from Aberdeen, Hoquiam down to, Chehalis, Centralia, that sort of area. And I am also an HIV researcher. I'm collaborating with Ann Collier on a project, and have collaborated with Jane Simoni, who many of you have probably met, on a number of projects. I work both in Kenya for my research as well as here in the US. And I'm a member of this Center for AIDS Research Behavioral Science Core. And the Behavioral Science Core really looks at studies related to risk behavior, behavior modification or behavior change, mental health, substance use, and how those impact HIV prevention and care. So I'm presenting a study that we kind of dreamed up during COVID to investigate how COVID was impacting the population that gets their care at Madison and its satellite clinics. And I'm sort of representing the team. Stefan is also on the team with me. And Stefan, please jump in if you have anything to add, or I make a mistake or whatever. Just to let you all know who's on the Behavioral Science Core, it's myself. Jane Simoni is the head of the core, the director. Other folks in the core who got involved in this study: Kristen Beam-Sophie, who's a qualitative research expert, David Katz, who some of you may know, and Judith Sui, who really focuses on substance use. Stefan got looped in fairly early when we were talking about community engagement, and had really sort of helped advise us as we got going. And we worked with Heidi Crane in the clinical core, as well as Lindsay Legg and the team at Madison, who helped with recruitment, so that we could kind of figure out how to access the Madison patient population during a time when they weren't able to access the clinic. Another thing, besides helping us figure out at a time when we couldn't do much of our research and when we really were limited, but wanted to find out how people were doing, we had a number of students at the University of Washington who also were somewhat at a loss for projects, for their training. And so we engaged a number of students who were really interested in working on this project. Their names are here. We've got an epidemiology student, MPH, 2 global health MPH students, a MedStar trainee that's a medical student interested in substance abuse, another MPH, a global health internal medicine resident, a lot of folks who needed research training got involved, and Stefan is helping mentor, as well as some of the other folks on this slide, those trainees.
Great. And so is that normal? That's not normal, in other words. You had more than usual.
Oh my goodness. Yeah, probably more than usual, which was great because it took a little bit of time to kind of whip the study together, get IRB, get the questionnaire design a red cap, because all of this study was done online during the COVID period. Where initially, as we started recruitment, everything was telemedicine. And so we had to reach out to folks this way. And yeah, we were lucky to have a lot of student help because, so many things got canceled, as you all know, starting in March and April of last year. And so we had a number of students who had planned either global health electives abroad or, work here in the States where they'd be out in communities, and they couldn't do it. So we kind of put our heads together and said, let's do something and find out how people are faring in this horrible time. So I'll show you a little bit about, this is what we decided to focus on in terms of the study aims. We really wanted to first just see how people living with HIV have been impacted during COVID. So that was an important one. In terms of, the pandemic itself, in terms of social distancing stress, job loss, housing, quality of life, all of those things. So we sort of designed a questionnaire that assessed many of these issues. We wanted to look at COVID stress and the stress related to COVID and its impact on mental health, substance use, and the HIV care outcomes that most are affected by mental health and substance use. So for instance, sexual health and HIV treatment adherence. And we wanted to look at whether buffers or basically coping mechanisms would help people and what would help them cope. So you'll see it in the next slide will be a conceptual model we used. But we also wanted to use the opportunity to look at patient experiences with healthcare as it sort of got cobbled together during COVID. So including telemedicine, online counseling access, pharmacy delivery services, laboratory appointments, to go places where they weren't necessarily seeing their doctor, but going to the nearest lab to go and get their masked up blood drawn. And so it was a little bit of QC with a strong sort of mental health focus.
And Susan, may I ask you a question? What is proximal and distal?
That is going to be a little better explained by this conceptual model. So awesome. We adapted a model that is, so stress and coping models are common in psychology. And, it's the idea that basically people who have decent coping mechanisms, social support, coping skills, knowledge that can help sort of deal with stressors tend to do better than people who experience those stressors but don't have those resources. So we started from a sort of a stress and coping approach, and then we looked at the two areas that we were very interested in, so mental health and substance use. And we sort of, when we talk about proximal and distal, we really thought that the COVID impact would be most immediate on mental health, and because of the impact on mental health on substance abuse, because as we know, many people self-treat for their mental health symptoms. And then we thought, well, distal, that the sexual health and HIV treatment impact of COVID stress was actually more likely to go through the mental health and substance use channels than to necessarily be that, if people had the same mental health and substance use they did before, they probably wouldn't have changes in their sexual health or HIV treatment. Mm-hmm. So this is the model that we developed. Any questions on that?
So the thing, when I think about this past year, I also think about how soon after COVID, with George Floyd's death especially, we had racial equality and all of that. And I feel like that was also added stress. Did you look at that, or did you add anything into your study like that once that started to?
What we did, so we did capture, so of course we captured race, ethnicity, we captured foreign-born status. I wish we had captured legal status if people were immigrants. Mm-hmm. This is something that, in retrospect, it would have been nice to ask a few questions related to stress, related to racial justice. And we just, unfortunately, sort of, kind of had gotten the ball rolling as that all developed.
Yeah.
The epidemiology student that I'm working with is looking at whether foreign-born status moderated the impact of COVID stress. It doesn't look like so much, but I think that's part of when I look at the foreign-born population we reached. It's really, it's only half of the foreign-born are from countries that are from the global south, let's just say. I mean, we've got Yeah. Oh, I was born in Ireland. I was born in Canada. So that is maybe not a perfect measure. When one of our participants joked that he was from Hoboken, and therefore born.
I
So
don't know if I'm missing it, but it
yeah, Bill.
seems like the impact of isolation would have been part of this.
Yeah.
Am I not seeing it, or?
Yeah, so definitely social support was part of what we measured. So, our challenge was to try to put together a web-based questionnaire that would capture a lot of these concepts, but without making it inordinately long. We used a tool for social support that is called the MOSSS, the modes of support. I think it looks at what kinds of help you get, like instrumental help, like can people pick up your, help you with grocery shopping, help you get to the hospital if you're sick. But it's also, do you have someone to listen to you? Do you have someone to turn to, to discuss problems you're having? So that was there. And then the coping scale we used also sort of looked at your ability to go to people for help. So do you have those kinds of supports available to you? The social distancing stress questionnaire also had a little bit about sort of how has, and the housing challenges asked about how your social circle got impacted. Like, are there fewer people, more people in your house with you? And that sort of thing. I'd be happy to share the whole REDCap questionnaire with folks here, because we're actually sort of also looking for different ways to analyze. We've gotten a couple of analyses going now with our trainees, but it's a fairly rich data set with a number of different questions. So it probably took about 45 minutes to complete. And we scraped together, we had really no budget for this. We didn't do the typical let's apply for a grant and then wait to get funded. What we did was a couple of us hadn't been able to take all our salary on the CFAR core. I had a bunch of what are these called, these Tango electronic cards left over from a prep study I'd done where we hadn't reached our recruitment target. So repurposing, I had some money left over from a budget that I had a sort of professorship, the George Anderson professorship, and used the last of my money for this study. So it was kind of a hodgepodge. Let's put together a study quickly. And I think we hit some things really nicely. There are a few things in retrospect I would have liked to ask, but we didn't. So this is what we have so far, and this is sort of the design that we used. We aimed to reach 400 participants, and that was sort of based a little bit on how much money we had to scrape together some reimbursements. We only reimbursed at, I think it was $25, so it was not a huge reimbursement, but we found that a lot of people were happy to talk about their COVID time. We asked at the end of the online survey whether people would be willing to be contacted for an in-depth interview. And our aim is to get up to 40 participants for that. We reached out to people who had enrolled in the UW HIV patient registry, and that was because those folks often had consented to be contacted by email or phone. Mm-hmm. To learn about studies, and that was our way to get to them without being able to recruit them in person at Madison. Right. And so they were basically, what was fun was we were able to actually recruit at the satellite clinics, which I loved because I'm a satellite clinic provider. Mm-hmm. So we didn't just have somebody sitting in Madison and leave out our Bremerton in Olympia and the other different sites. So that was nice. That's everything awesome. Was no contact. We gave emailed out electronic reimbursements to people, and we basically had the team of students was helping sort of man. We had a HIV and COVID at uw.edu the study email that we used.
Cool.
Yeah, it was fun. It was the first time I'd done that. So a lot of us learned a lot about REDCap by doing this. This is, and I'm sorry I did not have the time to update because I'm on clinical service. This is our the demographics for the first 343 participants. We ended up with 397, and I just haven't had a chance to update. But the majority were still from Harborview, but we did manage to get some participants from Kitsap, Olympia, Federal Way, and Snohomish. Race ethnicity was, a decent mix, actually. 69% white, 11 Black, 8% Latinx, 6% API, and 4% American Indian. And that's actually not statistically significant from the overall population of the HIV registry. So that was at least encouraging. I was afraid we wouldn't get much of a mix. 82% were male, 15% female, and 3% non-binary. And that's also fairly similar to what the HIV registry is. Now, I think the HIV registry itself may be a little more white than all Madison, because there are patients who decline to participate in the registry. But acknowledging that bias, this was the way we could get to people quickly.
One question, did you ask about transgender?
Yeah, we did. And we did not have any trans male or female participants. And I've looked at the registry. It's a very small number.
Right.
And so I don't know, we did try with emails and we just kept sending batches from the emails that we had. And then we tried reaching out by telephone. We found telephone was actually horrible until we learned to do a protected text messaging service that we were able to reach out, and we were able to get younger people with texting. Emails, many just went in unanswered. And so it was kind of who was paying attention. And then we tried some telephone to older folks, and unfortunately the problem with having older participants who sometimes didn't have an email was we couldn't reimburse them, and we couldn't really guide them through the online survey.
Right.
So those are definitely acknowledged limitations.
And
but yes, I was surprised we didn't get at least a few transgender patients in the survey or participants.
What service did you use? That protected texting service?
Oh golly, I'm gonna blank. It was one of my young people.
Okay, yeah, I was just curious from that.
It was Francis, and I don't know, Stefan, if you remember that. There's a name for it, and it's not Zip Whip, which is what the clinic uses, but we did figure this out, and that was the wonderful thing about working with young people.
Yeah, they could do the figuring out for you.
Yeah, they did the technology.
That's great. Well, yeah, I'm sure you can figure it out. I'd love to just learn, so I'll check back with you later.
Yeah, I can check with Francis. That's easy enough. He's the MPH Epi student who did a lot of the outreach by phone at the end. We just tried to get we kind of ran on steam with the email responses, and so then tried to whip up some more by phone.
You got close to your target, so I mean,
exactly. Yes, we did fairly well. Definitely older, but then, as we all know, the population of people living with HIV is aging.
Yes.
We weren't super successful with the 18 to 29-year-old crowd, and I'll have to check this against the Madison clinic. I think we were a little skewed older.
Yeah, I would imagine so, because I think that in general, it seems like that age bracket is a hard nut to crack for everybody. Everybody's wanting to do stuff with them, for them, and no one's really had any true success yet, I think.
Yeah, and catching them where they were in clinic might have worked a little better for that group. And we kept thinking we'd be able to start in-person recruitment, and we just ended up having to stop because just do it all online, because Madison is still a little stringent about the actual in-person participation right now.
Right.
So
I have a quick question.
Yeah.
Is this an ongoing study or a completed?
It is completed now. We decided to close 1 year after the date that Governor Inslee announced social distancing. You know, we weren't even sure. When we started this, I was afraid we'd get going too late and COVID would be over, which turned out not to be a worry. But as things progress and are opening up, we decided to sort of limit to the year of COVID, which we defined as March to March. So we closed in March. We got 397 participants, just shy of our mark by 3, because strangely we had 3 people who participated a little bit in the survey but didn't consent. So we had to remove them. They may just have misunderstood something. So, and I'll tell you a little bit more too about why we did a year period, because we'll come to that. We did ask, but we did ask people for permission to link their survey to their chart, and that was because we wanted to look at viral suppression. And so when we did a chart data poll, which we did in April, from the UW HIV registry, we pulled viral load data as well as some mental health data from from Heidi Crane's sort of the PROs, the patient reported outcomes. So we pulled data from the year before COVID and the year of COVID, so that we're able to sort of do some comparison across the 2 years for our population.
Wow. And Susan, I see you have your hand up. Would you like to ask your question?
Thanks, Michael. Hi, Susan.
Hi,
Can you talk a little bit more about the distinctions in the job or job opportunities questions, like lost job versus?
Right. Yeah. Shoot. In terms of the questionnaire, we basically we asked people, you know, have you during the COVID period or since COVID started, have you lost a job? So 26% said that they had. We asked people in several instances whether different things had increased, decreased, or remained the same, because we weren't quite sure. So we actually asked them, have your opportunities to find work or to work increased, decreased, or remained the same since COVID started? And 41% or so said that they had decreased. And a similar percentage said that their paid work had decreased. So there definitely was an impact in this population in terms of their employment.
Do we know what the general numbers would be for the general population for like lost
that
jobs?
I need to, I don't know. And I was just thinking about that. I was like, I know someone's going to ask that. And I don't know in general, I think that's higher. You know, the population is, you know, this population it has more people with below the median income. And as we know, the job impact really fell on, you know, folks who had sort of more blue collar jobs or, you know, sort of retail service jobs.
Gig workers. Yeah.
So,
I mean, that's really true. I mean, totally for my whole social circle, it would probably even be higher, those numbers, because lots of waiters, lots of hairdressers, lots of all those things that we all take advantage of when we can. And then they were all out of work for extended periods of time, unable to get the unemployment, you know, like it was just a mess.
Yeah, and that's why sort of in addition to just asking about job, we asked about job opportunities and paid work, and you know, so you can see, you know, in terms of a formal job loss, it was less impactful than just work opportunities to make money.
Yeah.
Right. So that would capture people who like are in the gig economy or are self-employed or, you know,
or carry multiple jobs at one time to make ends meet. Yeah.
That's really significant.
Yes. And I think that this is something we haven't written up yet to sort of compare to the state data. I mean, only 4% had lost housing, which is great, but you know, 43% were concerned about losing their housing at the time they completed the survey, and people had, of course, a reduced ability to pay rent or mortgage. So clearly housing struggles, as we know, happened. A lot of people said they were more crowded at home, so over 10%, and a lot of folks were having to support others. So that increased in this population. We haven't really looked at this data with respect to our mental health data. There's still quite a lot of work we could do to look at this. I mean, in terms of experiences, in addition to the interviews we did, we actually just had an open text question at the end of the survey where we told people just type in whatever you want about COVID. And these are actually not from interviews, but from that question. So, and people just gave us really beautiful things. I mean, times are more stressful than before. Things weren't good then. I'm not as alone with that situation, at least. I can't decide if that's good or bad. Or, I truly hate not going places so I can get out of the house. It's making my mental state worse. Young person there. Been very challenging to stay safe and keep my head up. This was helpful to vent out some things. A lot of people actually expressed in that space appreciation for the survey and the chance to report how they were doing. It's been a blessing in some ways. It's also been pretty damn emotional going through a divorce right now. So it sucks a lot more than before. I really miss touch. So really some, the interviews are quite interesting. We definitely had an interest in substance use, and one of our trainees, the medical student who's in the substance use training program, is evaluating our substance use data. Smoking increased quite a bit, and actually it's the most significant association between our COVID stress score that we calculated and a substance use outcome was with increased smoking among smokers. So, this is, of course, not everyone smoked before, but among those who reported any smoking, fully a third said they were smoking more, which is sort of disturbing in the light of COVID and lung risk. Some people increased alcohol and marijuana, probably more increases than decreases in alcohol and marijuana. And there were just, as everyone knows, there were some changes in availability of things. Some people didn't leave their house to get things they used to. We haven't examined our other substance use in depth. We did not get a lot of ID use. We got some former injection drug use reported by people, but as would be expected, probably for people answering emails and answering phones that are stable, we didn't get a lot of folks who are actively using other substances.
Can I ask, is the alcohol use and the marijuana use similar to smoking in that people had to use it before COVID in order to be described?
It's not that they had to use it before COVID. It's whether or not we just looked at the group that reported they used it at all at the time of the survey.
Got it. Thank you.
Sorry, I may have misspoken there. So yeah, this is among people who did report use. We asked, did it increase, decrease, or stay the same? We also have, we use the audit score for alcohol and are using that in some analyses to sort of see, and I think that might be the next slide. Let me check, or we may go to mental health. This is sort of just this is kind of our preliminary data at this point, and we're really in the midst of sort of analyzing. A lot of patients, 30% reported severe anxiety. And I haven't yet compared this to mental health that's generally reported before COVID. We have to see if we can match the participants we have with whether they had any prior PHQ-9 or GAD-7 sort of assessments. So we're still cleaning that data. But at least subjectively, a lot of people reported worse anxiety and worse depression during COVID. So those are those numbers. We had a preliminary analysis. We submitted an abstract to IAS that got rejected because I guess we missed the special HIV and COVID conference, and they didn't want COVID. But we created a COVID stress score where we asked people, and they basically rated these items: not a lot, not at all, a little, much, a lot, extremely. So has COVID-19 impacted your daily life? Are you afraid of getting COVID-19? Are you afraid of spreading infection? Are you afraid of being an asymptomatic carrier? Are you afraid of COVID-related stigma, or has that impacted you? And how distressing has social distancing been for you? So when we did a preliminary analysis, we just looked at COVID stress above and below the median. And we found that stress scores were associated with higher GAD-7 scores, so higher anxiety, higher PHQ-9, so higher depressive symptom scores, changes in the number of sex partners. And this was interesting. It was both more increases and more decreases, including exchange sex partners. So some people cut way back and maybe that stressed them, and some people got a little wild and maybe that stressed them, or the stress led to that. So that was interesting. And then again, more increases in tobacco use. So that was in a preliminary analysis. Let's see what else we have. Oh, and then here's some preliminary data on the sort of pharmacy and healthcare access. So 13% reported decreased access to their pharmacy. Well, some actually had increased because, and when we would ask people about this, a lot of people switched over to pharmacy delivery by mail, or the pharmacy started offering that. The Zoom visits people talked about, but they didn't like them. They found it was difficult to try and show the doctor things that were problematic for them. And then other people just felt they were trapped at home. So this was a problem for them. In terms of refills and tablets for adherence, some people actually did struggle with getting refills or getting and taking their meds, whereas others, again, often it was through these changes to pharmacy delivery, found that they had better access. So it was interesting to find how that was somewhat variable. The vast majority of people were able to take their HIV meds, and in a preliminary analysis, we're looking at, in terms of viral load, we found, interestingly, that the COVID stress score was associated with self-reported decreased adherence to meds, but not actually with viral load suppression. So most people who were suppressed before remained suppressed. There were some, a few exceptions to that. Anxiety was really associated also with reporting decreased adherence. And yet when we look at the viral load, whether or not people are undetectable, it was depression that was really more related with that, and that's that's similar to that's like not a new finding. So that was interesting. And then more people got worried about their HIV and worried about their adherence.
Right.
So we stopped the recruitment, as I mentioned, on March 22nd. So one year after our social distancing started, we ended up with the 397 participants, sort of right up to the wire. I think we stopped like 2 days before that March end date. We have completed 24 interviews, and we're sort of purposely selecting from among the people who said, yes, I would be willing to be contacted. We are trying to select half people who were in the lowest tertile of COVID stress score, so low stress people, and then half highest tertile, so the high stress people. And then we're trying to get a mix of sex and race, ethnicity in those groups. And it's been interesting. So far, the folks from the high stress tertile talk more about depression and anxiety as big problems for them during COVID than the low stress people, who often say, I'm a bit of a loner and this didn't bother me. Yeah. So we, as I mentioned, we did pull the chart data. That was done in kind of the beginning of May. We're cleaning data. We're looking at different analyses. We have the one student looking at substance use. We have another looking at the viral load outcomes. and a third who is writing a qualitative manuscript on how on coping mechanisms and what people did to kind of get by.
Well, hold on.
And I think that's it. So
All right.
there are definitely some other, some preliminary results of those analyses, but I didn't just pull I decided not to pull all the preliminary stuff together yet.
Right. So could you, I just want to find out a little bit more about those 3 non-consented people, how that may have happened, because I know it's probably related to REDCap and the way that people could do it. Like, do you have any more behind that, like how that happened?
Yeah, so we were going to reach out to them and see if they really meant to consent, but then we saw that they actually just answered. Somehow they must have at some point said yes. This is what we think happened. They must have said yes. They started the survey. They only go to a certain point and then they stop. So
Okay.
what we're wondering is if they sort of like you're not really supposed to back up pages, but I think they may have backed up and then decided not to take it because they maybe thought it was going to take them a while.
Right. That makes sense.
That is to our best of our knowledge. And we decided because it looked like they didn't want to put the time into it and not to reach out to those 3 folks, and just let them go with their non-consent.
Okay. Hold on,
And
Susan.
of course, we're not using that data. We've dropped that data.
I'm going to mute everyone just so we can get rid of some of that background noise, and then I'll unmute you again. And there you go. Oh, now I can't unmute you. You can try to unmute yourself, maybe. Like I can't get you there. Ask to unmute. There you go. My button is not. There you go.
All right.
There you go. Cool.
Yeah, I got it. Got it.
Cool. So yeah, that was just sort of distressing to hear, like people whenever someone's getting into study, because you think of the informed consent process as the gateway into doing anything study related. So that they somehow got in there and then went back and you could go back. Would that be something that you could fix for future times using REDCap?
Yeah, there's actually an advancement now in REDCap sort of since we set it up, where they actually have sort of a signature type of process.
Mm-hmm.
It's a little different. Ours was sort of radio button driven, and you did have to there was the consent. They had to read it. They had to click. They were willing.
Right.
I think even with the signature, they could sort of sign, do a few questions, and then just close it out entirely. And we probably see a similar thing where we had a signature and then we have, a couple of questions responded to, but then X'd out. So I think with the signature, they can't go back and revoke the signature now in REDCap.
Okay.
But I think you'd have a similar pattern.
Right. And so I'd love to ask a question of Stefan. May I ask you one, Stefan?
You can ask anything you like, Michael.
All right. What would you like to see done with this data? What would you like to see this happen besides like writing a paper and all? What would you like to see beyond that? And how do you think it could help the community of people living with HIV in this area?
I think that the data could really help to inform how we think about one, point of delivery considerations for people living with HIV in in-person settings, as well as telehealth settings. I think that this is so it's a program consideration. I think that there may be policy considerations and implications as well to the data.
Thanks. Yeah, I feel a lot about the mental health, and I know a lot of our CAB members are always bringing up mental health issues as something that research should be looking more at. That just like with this COVID data here, I was just like, oh, well, now we just took something that was already a problem for a lot of people and just seemed to have made it worse.
I think that there's
COVID did.
I think that there's a systems thing, a systems consideration as well. I mean, I remember hearing a couple of times from advocates, one during the clinical trial process for COVID-19 vaccines, but certainly during the rollout, that people living with HIV were not prioritized. And, I just read an article in Nature recently that talks about the significant impact of COVID-19 on people living with HIV who have controlled viral loads. So there is a consideration here. And I think that to me, the broader consideration is even beyond COVID-19. It's for how we respond to people who may have compromised immune systems generally, and how do we better prioritize service and care to people who fall into this category, even post COVID-19, right?
Right. So I want to open it up to all of you. Any questions for our two guests that you would like to bring up? Or even a comment? What did you think about what they found? Did it surprise you? And remember, I muted you all, so you can unmute yourselves.
I'm going to share, if I can find it. I'm going to share a slide from that our qualitative trainee is using in her for her thesis presentation tomorrow. That I think is a nice sort of comment from someone on, regardless of how the care is delivered, this is the thing.
Wow. Wow. Please be kind.
They have many concerns. So I liked that she's pulling some really lovely quotes from the interviews.
That's wonderful. I love that.
Well, as I sat here listening to you go through this, I could clearly see, that the reasons tobacco use increased, alcohol increased. I saw that at QFC before the news announced that alcohol sales had increased dramatically across the US. And, for me, the 5th month, my depression became active. And it really wasn't until I realized I was missing medications that I realized my depression was active. And so, it just is a dozen different things that you can talk about with regard to depressive anxiety during the COVID, the isolation. I live alone, and I thought, I've been living alone all my life. This will be nothing. It was something. It was big. And, my smoking increased, especially during my depressive period. And so fortunately, I don't keep alcohol in the house, so my alcohol use didn't increase. So it's easy to see how those numbers are so high because I lived them. So the anxiety of just going to QFC, if I touch something, am I going to get COVID?
Absolutely.
You don't know how high that anxiety was and what it did to me. I waited until my refrigerator was absolutely empty before I went to QFC. So.
Yeah, there are some of our interviews talk about the struggles people had with their families and even partners when those significant others or in their lives did not follow social distancing, for instance. And a lot of folks living with HIV are very aware of viral infections and how easy it is to get them. And so, there are some really just challenging stories that people had about, having to tell their family, I can't see you in person because you guys won't wear masks. You guys won't follow the rules.
Susan or Stefan, did anyone actually get COVID? Did you ask about that? Or did you ask about the vaccine?
We had only one person who was interviewed, and honestly, I should run that again. It was only a few cases. We had 4 or 5 cases the last I had checked, but I think maybe 10 total. It was, now that we've got our final data. So most of our data is on how COVID impacted people who did not get COVID.
Mhm.
Almost everyone talks about people they knew, and we had a section of the questionnaire where he asked, did you get tested for COVID? If so, how did you get tested? How many times? Did you have COVID yourself? Did someone in your family have COVID? So we have a lot of that data too, which I haven't even really looked at in depth. We're thrilled to have the data because I think it's, it's really rich in terms of exploring. And the other thing that's really just serendipitous about this study is, I don't know, Michael, if you had announced to this group that there's a new HIV Center for Mental Health.
I was going to close with that, but please go. I love it.
Well, yeah, and you probably have the actual name. It's something called BIRCH, which I think is the Behavioral and Interdisciplinary Research Studies for HIV and Mental Health.
Something like that.
It's basically a mini, it's a developmental CFAR, but it's a mini center, developmental center that we'd like to grow up, and it's specifically for HIV and mental health.
Yes.
And it's being directed by Jane Simone and Pamela Collins, and I am the associate director. I'm sort of the clinician on it. And Michelle Andrasic, some of the folks are on our cabs. Stefan certainly is being involved and asked to help with our community engagement. But it's kind of nice to have this data because it's also letting me see what we can get from the charts, and what are the strengths and weaknesses of that. What are the how do we ask questions, and what should we be measuring when we do these kinds of studies?
Mm-hmm.
So, very
and
useful.
Are you getting any feedback from the people who took the survey about the taking of the survey, like things that maybe they could tell you about how it went? Do you have any sort of post-study interview that's not really about the data so much as about the experience of giving you the data?
Well, to a certain extent, the interviews themselves, the qualitative interviews, do capture something about the quantitative because they're people who did take the survey.
Mm-hmm.
That little snippet where we left the big open blank field
Mm-hmm.
and asked people just to type in what they said. I think, maybe one or two people talked about trouble with sort of like getting through the survey,
Mm-hmm.
but the vast majority just said, wow, this was great. This was great to go through and realize sort of what is happening to me. It was a interesting and useful exercise for them. And they usually, there were many people who just said, thanks, lots of love. Hey, COVID.
Hey, can I ask a question?
Yes, go ahead, Kate.
I'm kind of curious, how similar in a disease is COVID versus HIV? Because it attacks the immune system in similar ways.
Yeah, the COVID really attacks sort of lung tissue, though, a little more, and respiratory. It's more of a respiratory virus, like a common cold. And at least we know, thank God, you can get rid of it. Like once you're over and you've recovered, you just have some immunity to it. Immunity is better if you get vaccinated. Mm-hmm. But it is really much more like a influenza type virus than it is like an HIV sort of long-term sort of chronic that we can't get rid of yet.
Well, and not everybody who gets COVID dies. But we know that if we didn't have antiretroviral therapy, basically getting HIV was a shortening of your mortality, and that's a big difference.
Yeah,
the body doesn't seem to recognize where HIV is, so HIV is a far more complicated virus.
I know they both attack the immune system, and I've read articles where they were finding out that some of the proteins in HIV were similar to some of the proteins in COVID, but I wasn't sure how much actual factual that article that I read came from. So it was something that I got from somebody on one of the groups I'm in. So I didn't research the article itself. So that's why I was asking that too.
Yeah, sure.
That's a really good question.
It is. And if you have that article, you could send it to me. I can help look, look into it for you.
Yeah, I'll have to
Wonder-
go back and see if I can find it.
Okay.
I want to chime in also, just because I know that the public health messaging around this has not been adequate by any stretch of the imagination. And that is just to say that COVID-19 is actually the disease and not the virus. The virus is SARS-CoV-2.
Mm-hmm.
I liken it to SARS-CoV-2 being like HIV, whereas COVID-19 is more like AIDS.
Right.
Yeah.
It's challenging.
That's why I like doing these with Michael, because you get people that actually know what they're talking about, and it's not like I have to go with the guessing game. Is this actual factual? Do I have to research this to find out? I mean, there's just so much mixed information out there.
Yeah, the messaging around this has been terrible, honestly.
Yeah.
Just having two different names in itself is somewhat challenging, but yes.
Right.
But I mean, wonderful that we were able to come up with a vaccine for COVID within a year. As we started our study, we had no idea it would last a whole year, that we'd be living like this for longer than a year, really.
Yep.
But yes, Michael, if you can just whip up the cure group to try and make that same progress in HIV, that would be
Sure. No, they're whooped up. I think it's just a matter of that. It's a really difficult challenge with curing HIV. It's just from embedding into the DNA to the way it can just, it replicates so quickly that it is, it's got every defense mechanism. It is truly a master sleuth, that it just seems to know how to use our own immune system to evade our immune system.
And we will be talking about this on the AIDS and 40 session on June 2nd, actually.
Yay! Good. Yeah, so that's going to be crazy. Did anyone, should wrap this up, I just wanted to make sure, were there any other questions that people had? Laurie, you were awfully silent. Calling people out, teacher.
I don't have any questions.
Cool. I
know it's rare for me to be quiet.
That's what I was like, whoa, is she there? Well, I'm glad you could at least hear it, and to hear the news about the mental health. I didn't know if you know about the mental health developmental center that's going to be forming.
Yeah, I had heard about Jane's grant. Yeah, that's wonderful.
Yeah, it's exciting.
great.
Well,
It
feels like we are at our end of this. So if there are no other questions, I wanted to thank you, Susan. Thank you, Stefan, for joining us tonight and sharing your data with us, because I think we've learned a lot. It's probably helped a lot of people feel like that. If you all can get to your reaction buttons, that's the way you can clap the best right there. Hit a clap or hit a heart, whatever you want to give them. But I want to thank you both for joining us. And I want to thank each of you who did come on a semi-sunny day here in the Seattle area and decided to come to a webinar. I really appreciate you showing up here with your sort of fastidiousness month after month. I really do appreciate that.